without any more delays, I will propose the conclusion of this table. If you allow me, I would address Dr. Elizabeth, asking her if, after presenting us with all of this availability in multimodal monitoring, and knowing that some of these devices are yet not available in some neuro ICUs, in your opinion, what would be the best investment in order to improve the outcomes in neurocritical care patients?
Okay, thank you very much for your question. It is a very good question, and it's a very practical question. And I think it's probably the most frequent question that people ask me after the lectures about multimodal monitoring, because in fact, I've presented what we do in our daily routine in our NCCU, but even in my hospital, we have 2 other units, and we don't have all this monitoring in the other 2 units. This is something that I was very curious about, and it was the first part of a work that I started a few years ago, about knowing much better about what we can offer to these patients in order to improve their outcomes. And in order to do that, I start comparing the, different units, but more than comparing the units, I compared what we offer to patients. And I compared in a group of 389 patients, I compared 2 different groups first. I compared patients that received advanced multimodal monitoring against the others. And in fact, the results were very amazing, because in fact, they confirm what we expected. The group of 69 patients that received the advanced multimodal monitoring had better outcomes, and also better mortality rate, even after adjustments for Glasgow Coma Scale at admission, after adjustment to severity scores, and after adjustment to age. So this was the first point. But this just confirms that in fact giving more neuromonitoring means improving outcome. The question that you are asking me to answer is different. So if I don't have this advanced multimodal monitoring, what should I choose? What should be the investment of the ICUs? What ICUs can improve in order to improve outcomes? And I think that probably, and I think I stressed this in my lecture, the first thing is the team. We need to think that these patients need a dedicated and differentiated team. Okay, I don't have the PRX, but I have nurses that can go through patients and they can do properly neurological evaluation. They are able to use and to evaluate the pupil size. They are able to manage the autoregulation. Even if they don't have PRX. I think that this is the most important thing. And I tried to demonstrate that, because we compared in our intensive care department patients that received the same monitoring. I mean, the patients that don't have PRX in general ICU, and also patients that don't have PRX in our NCCU. And even with these limitations of neuromonitoring, patients at the NCCU had a better outcome, even after that adjustments that I have already referred. So it seems that a proper management team, a proper team that is able to manage patients properly is the best thing that we can offer to this patient, more than the devices, because sometimes you can have lots of devices and people are not able to look at them. We know this when we receive young doctors. They are very keen in looking at all the devices, but they are not able to take decisions regarding the devices. Usually the nurses and the senior, of course, the senior doctors there help them through the process of learning to manage devices, but first manage the patients and clinical evaluation and recording at the evaluation, the clinical evaluation, and other basic things like pupil size or look at the ICP curve and other stuff.
Formation and training.
Yes, training, but proper and differentiated training. I mean, we need a very skilled nurse and a very skilled doctor, but focused on a different way of seeing the patient. It's not enough just see the general patient. We must take care in little things.
And taking that topic, Professor Lara, having the EEG, an interpretation curve that takes so long to acquire, how do you idealize that this training in EEG can be accomplished in intensivists in order to optimize the use of the EEG in intensive care units in a diffuse manner?
Yeah, that's a very good question. Thank you. I think so. We recently looked into that with colleagues from Toronto, with Victoria McCready from the Toronto Western Hospital in Ontario, in Canada. And we did a systematic review looking at all the available literature out there about education and training programs for EEG in critical care. And what we found is, although we weren't looking at effectiveness, because that's a very difficult thing to do, there isn't much literature there looking at effectiveness of these teaching programs. Most of the programs were very short, limited to 1 day. They were focused on neurocritical care nurses or critical care nurses, and few of them were looking at doctors or doctors in training. And most of them were looking at using trends, so from the quantitative EEG instead of the raw EEG interpretation to start with. And I think, in my opinion, this is a very good, actually, approach, because quantitative trends are somehow simplified versions of a very complex EEG. And although the endpoint would be for intensivists to be able to have a basic skills in the interpretation of the raw EEG, I think starting from the quantitative trends simplifies also the training programs. So keeping it short to 1 day, probably with a series of lecture and cases, and probably with pre and post course quiz as well to assess the effectiveness of the course itself. And then ongoing monitoring and ongoing training and updates of staff would be ideal. And looking at the agreement between the interpretation of quantitative EEG trends between staff, ICU staff and neurophysiologists is variable, actually, in the literature. There are some studies that report a very good agreement, and some others that report moderate agreement. But I think that relies very much into the quality and the intensity of the training programs. So this is what we do actually in Oxford. We schedule very short sessions of 1 day, and we repeat them recurrently during the year, quarterly. And time to time we update and we upgrade the course as well for those who want, because not everybody wants to take the skills further, really. So yeah, that's it.
Okay, thank you very much, Professor Lara.
Thank you, Lara. I think still we have a problem of a dissemination of the EEG learning in the intensivists. And I think that maybe the European Society may take a look to that with your help and the help of others, and try to build some kind of skill or course that will be available for more intensivists that want to learn EEG. And I agree with you that the quantitative EEG is maybe a good way to go a little bit further the difficulties of the raw EEG. What do you think also about those equipments and devices that allow us to get some EEG with less channels, like Cerebere or other that we may think in the ICU environment?
I think they're useful for specific indications. Really, they're not applicable to patients who have complex epilepsies and are admitted to intensive care under the care of a neurologist and have ongoing input from a neurophysiologist. And that is because their epilepsies and their EEGs are fantastically complex. And simplifying to a low density array of electrodes on the head will lose a lot of information in those cases. Other situation is when you really are interested in the topography of something. If you're interested in the topography of ischemia, for example, then you would ideally like to have a higher number of electrodes. Also worth mentioning, the ACNS sets the minimum standards to 16 electrodes for critical care EEG. Now, having said that, simplified EEG is useful, I think, especially if you look at the grand scheme of things, and if you look at very prolonged recordings, and if you look at changes over time, more than changes over topography. And the devices such as the Cerebere, which uses active dry electrodes, for example, that don't even need any prep, they have gel already embedded within the electrodes. I can see their usefulness in the emergency departments, in patients admitted with unconsciousness of unknown origin, to exclude seizures and status epilepticus there immediately. I think in the intensive care, we could have the possibility to use more advanced devices compared to the Cerebere, which actually its use is limited to the 8 hours, because after that the gel dries out, and it is very expensive to change those electrodes. So I think cost effectiveness wise in the ICU, it's better to use the traditional machines, to be honest. But I can see a niche usefulness of that device in particular.
Okay, thank you. I don't know if any other of the panelists want to say anything about this point. But I also would like to comment the lecture from Ricardo. I loved it a lot. It was quite a good lecture about not only the basics of TCD, but also about the applications in the ICU. And Ricardo, what do you think about the possibility of using a little bit more the TCD in a more continuous way and bilateral monitoring, so that we can compare different compartments in the brain, mainly for patients who have asymmetric pathologies such as stroke, or even different contusions in different places that may, for instance, induce autoregulation asymmetry in both hemispheres.
Hello. First of all, I'd like to greet everyone. It's a great pleasure to finally see your faces after recording our lectures in our own privacy. And regarding this question, in fact, the continuous TCD monitoring can be quite useful in a variety of neurological diseases. As I presented in my lecture, we may characterize different kinds of variables through continuous TCD monitoring, the flow velocities, but the autoregulation, it's also a very important factor. Regarding the continuous hemodynamic monitorization, the TCD may present us quite relevant data, despite the fact that from a practical standpoint, may be quite difficult to maintain and sustain this continuous monitoring, mainly regarding the loss of signal from the probes. Sometimes it's quite difficult to sustain this continuous monitoring. Regarding the autoregulation or the loss of the ability of the brain parenchyma to self-regulate its blood perfusion regarding the arterial blood pressure, this autoregulation may be impaired in a variety of neurological diseases as traumatic brain injury, stroke, the subarachnoid hemorrhage, and can quite often happen quite early, even before some velocimetric assessment discrepancies or differences. This loss of autoregulation is a predictor of a poor outcome and may highlight quite early in the course of any disease that any given patient may be prone to deficiency regarding the arterial blood pressure variation, even low blood pressure variation or higher blood pressure variation, because the brain parenchyma is prone to be systemically damaged through this variation. And this autoregulation monitoring may be quite useful to regulate in a more intensive manner the arterial blood pressure, even in the low or in the higher limits. So I believe that continuous TCD monitoring may be quite useful, despite the technical difficulties. We may have different alternatives as the near-infrared spectroscopy that may allow us to infer the autoregulation mechanisms, and technically is more easier to use in an ICU care environment.
Yeah, I think you are sure, because maybe we're still looking for that, but maybe the NIRS, maybe a good surrogate of cerebral blood volume that allow us to monitoring the autoregulation non-invasively and continuously, but still ongoing the proof of the concept about that. And I hope that also the robotics and some of new possibilities regarding the TCD probes evolve and may help us to get a more in a more easier way a continuous signal in the difficult environment of intensive care.
Regarding the robotics, there are some new devices that may continually reassess and reposition the TCD probes. For now, they are quite expensive, but I had the chance to try one of them, and they appear to be quite effective regarding the continuous monitoring. Even with patient repositioning, they accurately retract the middle cerebral artery. It was the vessel that is more often monitored, and may be an alternative, but for now they are quite expensive.
Yeah, but in the future, I think that there is an hope for that also. Thank you, Ricardo. And Professor Citerio, I am a fan of pupillometry, although in my country it's very difficult to buy a pupillometer, I have to confess. I still have some difficulties about the distribution and representation of pupillometers and the possibility to buy them in my country. I think that the evaluation of the pupil and the signals that we get from the light reactivity are clinical, very important, but also a little bit subjective when we are just looking at in the common way with the lights, but also a very important signal to track patients that may evolve to uncal herniation, for instance, in the emergency department and even in the pre-hospital scenarios. And so why do you think it's so difficult, or at least in some countries it's so difficult? What you may explain us to, so difficult to implement this technique that is quite simple and I think very useful in giving quantitative evaluation of this reflex?
I don't see so much difficulties. I think we can try to make you have a contact with one of the two companies that produce the device. I don't think it's a problem of availability of the device. I think if we compare what we discussed till now with the other panelists, the learning curve of the technique is very simple. The information is very sound compared to other information. And I think makes the basic of the neuroevaluation more reliable and quantitative. So we have some numbers, we have some trends, and so we can make take some decision on the trend we will have. So I think we can also help you in try to have a pupillometry in your center is not a problem. But I think that returning back to all the questions we deal with in this short section, I think we need to put in our unit the device we are able to manage it, to understand. And I think the learning curve is an important point, but each monitoring gives us some information. And what we learn also from the previous discussion, also from the first answer from Sophia, I think that the link between the therapy and the recorded value by EEG, by transcranial Doppler, by pupillometry, by brain tissue oxygen, whatever you want, needs to be evaluated in a treatment protocol for having some result. For pupil, it's not so difficult because if you have a sign, you can try to at least reduce ICP or doing other maneuver and try to return back to normality. For other setting or other monitoring is more difficult and more complex with pathology. But I think also we try to explore the effect of high ICP or higher ICP on pupillometry, and we are using the device for also other inference, probably in center or in setting in which ICP could not be monitored. Some of these non-invasive tools could help us in getting some information in different settings. So I saw a bright future for the pupillometry, and I can send you an email afterwards to try to help you in finding a pupillometry in your center.
Okay, we are now trying the neurolights, but for instance, with neurooptics, we never had the chance to get in contact with American manufacturer, although we have already sent some emails. But I would appreciate your help. Thank you. One of the things that I am curious in studying and learning a little bit more about brain function and the connectivity between the brain and the body is the autonomic nervous system. And for that, we have doing some studies with heart rate variability. But when we look at the pupillometer, we also, of course, see that maybe we can also get into the autonomic nervous system with the pupillometer and the balance between the sympathetic and parasympathetic tonus. What do you think about that? Do you think that maybe in the future we'll have a little bit more information at bedside about the tonus of the autonomic nervous system, taking into account the data and the variables from the pupillometer?
I think that the pupillometry could have some interference from the autonomic nervous system, but we cannot explore it except, for example, when we test the reaction of to pain and so on, and then some interference from other system. On the other hand, the pupillometry we are using is mainly based on some derived indices, like the neurological pupil index, that doesn't have so much interference from drugs and other, let's say, perturbation outside the reflex and the compression of the brainstem. So the normalization of this problem, like the autonomic nervous system activation or sedation, that could have a lot of influence on pupil, is taken in account in a calculation in which all the parameters are put together and they are balanced, and the autonomic nervous system activity and, for example, sedation are not presented in the result of MPI because they are analyzed all together, and the MPI is not affected by these parameters, so but by external factors. So my suggestion is to try to use a derived index like MPI, and at the end MPI is a very solid index, let's say, looking at other outcome parameters, ICP, and other setting, not influenced by what you say. So I think by using derived parameter is better than using only, let's say, the pupillary light reflex, the tone of the pupil, the size of the pupil, and so on. But this parameter could be influenced by, for example, opioid and other external factor, and these external factors are abolished by the use of an index that takes into account everything.
Okay, I'd like also to open the discussion if anyone of the panel want to change your opinions with us. No, if then I would ask Gustavo to finish this discussion.
I would like to thank you all for your availability to being present here and the time you spent with these lectures. We are very honored with all your presence, and we would like to wish you all a good rest of Congress. Okay, and thank you very much once again.
Thank you very much.
Thank
Thank
you.
you.
Thank you. Bye.
Goodbye.